Excellent. Many thanks to you both. And I have a few questions to start off the discussion, and then I'll turn it over to the audience. So think about what questions you'd like to ask. But first, Amanda, I think you laid out a few charges for the global health community to consider as we think about these transitions around new products, global public goods, and equity. I'm wondering, as you think about these transitions, countries will also play a more directive role in their own procurement and thinking about their own priorities. Can you comment on what changes we might see as countries take more control over their procurement decisions? What product changes that we might see? Where might they invest in different health areas? And how should we as a global community support them in that effort?
So, well, I think I'm a little worried about what that will look like in the near term because we're seeing a tendency towards fragmentation in some of the low middle income countries in terms of the way that they're purchasing, but eventually that will revert. So I think what we need to do as the international community is first help with data visibility into these markets and to, you know, I think there's let me back up. One thing that would be really useful to start with is standardization and serialization of medical products. So I actually didn't realize this before I started working in this area, but even an aspirin or something like that is not fixed with the same product identifier or the same labeling requirements. And there's no track and trace, let's say, in most health systems in middle-income countries today. So there's a lot of interest in this idea. It's certainly worked very well in the retail sector to be able to do better. I mean, I'm concerned with it from a procurement perspective because I'm concerned about holding too much inventory at one time, which has a huge cost, or because I can't understand what the demand actually is to be able to do demand forecasting well. But you also care about, if you care about quality and substandard and falsified medicines, if you care about effectiveness, et cetera, right? So I think there's a set of interventions around data, standardization, serialization of products that at baseline that the international community could really help with, that would give us greater visibility into these markets, both on the public and the private sector. And that will make those purchasers smarter too. Because, you know, if you don't really know what you're asking for, or if it's not even on your list, that's one thing. The second area that I mentioned also is around how do we assess what products to buy? There's a whole set of things that donors are buying today. Should country governments take those on wholesale, or should they be making some tweaks? You know, they're buying some things themselves right now that sometimes require a closer look. So some support to do health technology assessment, cost effectiveness, budget impact analysis to understand what is that set of medicines. You know, there's a bunch of recommendations, but what is cost effective and most important in my setting? So a set of support around that. And then I think there's a set of kind of reforms that I'd like to see, regulatory reforms that would enable easier market access for non-branded quality generics manufacturers, for example. And there have been some efforts to harmonize regulation that I don't know exactly what the status of those is right now. But what I understand is even if they've harmonized the dossier to access the market, they're still asking for fees from these manufacturers to enter the market. And these are, you know, they're making enough money elsewhere. They don't need to go into Guinea. They don't need to go into some of these countries. So maybe we need to think about compensating the national regulatory authorities for these foregone fees or something like that. Because the goal is to get as many competitors into those markets as possible. That will bring the price down. And that will work not just for the public procurer, but into the private markets as well. So that's a big set of reforms that I hope to see.
Excellent. And Johanna, I think you were just noting the future is now. We are already thinking about non-communicable diseases, and the spend is happening. As countries, again, take over more of their own budgets in the health space by necessity, how do you think that will affect the NCD space?
Well, I think it can go a variety of ways, and I think again that sort of that +1 approach of sort of an integrated approach to purchasing is going to be enormously valuable. We're already seeing a lot with, and thank you, Amanda, for talking about both diabetes and hypertension meds. Those are the two areas that seem to be already there's a lot obviously going on with that, and I think those are sort of the low-hanging fruit in the areas of greatest need. So I think what we need to be doing is taking what we're learning in different places in a somewhat fragmented way and try to be a bit more coherent about that. It's not, that fragmentation is true across NCDs as well as across the other sort of the big three as well. Thanks.
And Johanna, I'd also just like to pick up on something you alluded to earlier when you were speaking about multi-sectoral engagement, and what we heard earlier from Peter Sands about how some public sector partnerships and public-private partnerships can be controversial, depending on which type of sector we're engaging with, which type of company, and what they're associated with. Could you comment on that for the NCD space, since that may have many different implications around industries related to sugar-sweetened beverages, agriculture, et cetera?
Yeah, no, it's a good question, and it's interesting to me, honestly, for being in this room, because I've been living in Europe so long. I'm used to much more of a kind of reflexively well, a less warm relationship with the private sector is what I'll say, and so it's quite refreshing to have spent these 2 days here. I think there's these distinctions need to be made across there are health harming industries. There are health harming industries that can become health positive industries, health enabling industries, like food is the obvious one. I think there are health harming industries that are non-starters, like tobacco, but I think beyond that there's a need to recognize both the products but also the value, and of course, as Peter was saying, there are large employers, and that particular partnership in question, which he's certainly been in the spotlight for, was around actually using kind of the supply chain within that particular company. It wasn't around sort of direct monetary. So it's frustrating that sometimes those nuances of that companies have enormous skill sets and capacities that can be really, really valuable. That gets lost in the mix. I think we do need to make these distinctions, but obviously there was also, and I thank you for alluding to there was a challenge with the NCD Commission report around the fact that tax on sugar-sweetened beverage didn't make it into the final document, whereas tax on alcohol and tobacco did, and it's sort of good to put it out there. And I think the WHO case is sugar-sweetened beverages at the time that the Best Buys were developed, it was a good buy, not a best buy, and so this was a disciplined focus on Best Buys. And I think there are other views. Of course, I'm promoting the Stacks view. I think sugar-sweetened beverages is starting to show some real resonance, and I think we would like to see that revisited and reviewed, particularly as the final political declaration for the UN high-level meeting is developed. But understand that there's some public elements, and there's a lot of complexities to this situation. So, but I think moving forward, we have to. Our only chance at a sustainable solution is finding ways forward with this, and it's one of the reasons I even talk about my health situation, because I'm the beneficiary of public and private partnerships around health that have developed innovative products that have allowed me to live a really, really great life. And there's a lot of us out there. Let's own that and not apologize for it.
Absolutely, and I think bringing in that user perspective and keeping that focus on the real impact on an individual level really matters. Amanda, I was also thinking through, as Johanna was speaking about the different interests that different actors can have around incentives and how tricky incentives are to get exactly right, especially when organizations are situated to work towards different types of bottom lines. In the private sector, of course, it is an actual bottom line, a commercial bottom line. And in the global health space, it can be a little bit more amorphous because we have multiple goals of access and equity and sustainability. How do you think about approaching market shaping or market-based interventions, and even some of the recommendations you outlined that can try and resolve that tension between different types of goals and incentives? Just an easy question for you.
I guess that there's lots of goals of health systems. It's not just health maximization. It's also financial protection. It's also equity. It's also being responsive to demands. So, any of the reforms that I've talked about need to take whatever that country's particular health system priorities are into account. could be cost control. I think from a transition standpoint, I think we have to, you know, if you asked me what I think, which is probably irrelevant, but if we have some money in that we've invested for many years to improve global health outcomes, and that's made possible by purchasing a certain set of products, we should at least make sure that some of that is sustained, whatever that cost-effective mix is for that particular budget envelope in that country. And I do think, we need to talk about lives saved. We do need to keep the focus on the bottom line, but we have a responsibility. If there is to be real transition, which there will be, whether we like it or not, then we need to put in place those mechanisms now and have the transition be the outcome that we care about in the near term, which is in some ways a lot less attractive than lives saved, unfortunately. But I think it's really important for us to change gears a little bit in the way that we're relating to governments.
Great. All right. So with the responsibility that Amanda just thrust on all of us to be helpful stewards in this transition process, let me open the questions up to the audience and see what questions or comments you may have for our two speakers.
Thanks very much for a very interesting panel. Yesterday, if I make two sets of comments, one yesterday and a question. Yesterday, Tim spoke about the demographic and epidemiological transition. Very, very clear about that, how we are transitioning to a new set of health problems. But my concern is, we are not transitioning our narrative. We still speak about 40 million people who die from NCDs. We don't speak about the 3 to 4 billion people who are living in NCDs. So I want us to make a transition to the narrative, because that old narrative related mainly to the infectious diseases where you died. So you lived or you died. But the narrative that we need to change is to focus on those who are, as Johanna points out, those who are living. And once you do that, you change the whole discussion. You change the whole discussion. So I want to encourage us to stop focusing exclusively on the dead. There's no constituency of the dead. Stop focusing exclusively on the dead and think of those who live with NCDs. That's one. And once we do that, a lot will change. The second point is with regard to procurement. I was struck by the point that Amanda made about the cost of some statin in Ghana. And the question I would have is, we talk about partnerships that are not only private-public partnerships. What is the feasibility of there being partnerships among countries to make those data available so that one country X knows what country Y pays for the same product? And how can that be done? How can that be done? Because I think the only successful scheme I know with joint procurement is in this part of the world. But are there other possibilities of ensuring that these, if there's not joint procurement, at least there's knowledge about what is occurring? The final point I'm making, I think it is absolutely critical, the point you made of harmonization of regulation. We need to have a lot more emphasis on harmonization of regulation. There is in the Americas a scheme for joint harmonization of regulation. This is something that should be global. Thanks.
Why don't we just take one more comment or question, and then we'll let you both respond. Joe?
Thanks very much for the panel. Joe Buford. I wanted to extend Sir George's question to push the envelope a little bit. One of the interesting statements we heard yesterday was the Wayne Gretzky quote, I think, that Tim gave about going where the puck is. And it seems to me a lot of our concern now, rightfully, is around transitioning a healthcare system that's the way it has been. And I was particularly interested in Mark Halliday's statements about what they're funding. 30% for hospitals, 30% for commodities, 30% for subspecialty intervention services, and 6% for insurance. I didn't hear the word primary care till the end of the conversation. So I think part of the thinking here needs to be towards where the puck should be going, because it would be more cost effective, I think. And that implies, in the United States, only about 5% of people who enter the formal healthcare delivery system ever end up in a hospital. And we forget the epidemiology of that reality. So I think part of it, I'd like to ask the panel to extend, in a way, I think, to think about the future healthcare system where there is no market. I mean, there is really not really a market for primary care at this point in this country or in other countries. There is not a market for prevention. It's developing. The narrative is developing, as Sir George said. And this notion that Johanna brings up, which is very important about the health impact of market decisions in sectors like transportation, housing, and others. There's more going on in energy than others in terms of LEED certification and green buildings and other things. But, you know, how do we move the needle into creating that market for where the system needs to be going rather than dealing only with the transitions we're facing now? And I don't mean instead of, I mean in addition to. Thank you.
Thank you very much for that, Joe and Sir George. Thanks. So in terms of where we're going, I thought the other really important point that Mark made was, whereas 5 years ago he was saying the next big, you know, it's all going to be dominated by China, the next big healthcare sort of breakthrough. Now he's saying it's going to be Amazon or Facebook. And I think, but there's a lot of truth in that. And I think the question will be, what does that look like across income levels, across geographies, in terms of the level to which health and healthcare are owned by the individual, and to Siddhartha's points yesterday around leapfrogging, and how is that going to play into this too. I think to even just one of the disruptions in primary care that I love, and I haven't looked at the evidence lately about it, but the Swasthya slate in India is one where, you know, it's essentially it's an iPad with that's replacing, you know, delivered by community-based workers, that's replacing a lot of what had been primary care in rural settings. So those are, and there's tons of examples like that. Those sort of, you know, technology-enabled primary care in some spaces. In terms of, I think we have a lot to learn from climate change about how you get that multi-sectoral approach, and so I would, you know, I think it's a critical piece because it's also it's a model that has sort of the environmental success and has worked across the consumer, changing consumers, changing shareholders, which is going to be really important as some of these issues are sort of driven by the corporate sector, and some of the solutions can come there as well. And so how do we change shareholder demand, shareholder behavior around that? Who are the shareholders? The shareholders are actually mostly the pension funds. So we have like all these sort of complexities there. I don't mean to just answer your questions with more questions, but I think that's kind of the truth is that there are more questions. And those questions go back to even incentives, to Amy's earlier point around how do we incentivize those non-health actors to be more health enabling. And it has been a surprising struggle, of course. You know, there have been these sort of debates around both in tobacco and in food, and those debates have actually translated into legal cases that have everybody, you know, mindful of some of these conflicts. So I'm going to just essentially answer your questions with more questions, but say there's I think a really exciting level of thinking that can be done around this about what does that look like, where is that puck going, and how do all these sectors and factors play into it.
Okay, I'm going to stop focusing on the dead. That was a very important call to arms. On your other question on this is reference pricing, and that's what smart procurers will do. It's a little bit of a there's lots of ways to think about this issue. You know, some advocate for transparency in pricing, but in the highest income economies, actually, that's not how they get the best deal for on-patent medicines. They get the best deal by publishing a list price and then negotiating deals within a framework agreement based on volume and, you know, auction and all kinds of other. It depends on what the market is like and what the product is, whether it's on patent or not. So I think it's really about, you know, having a strategy for product selection, price negotiation, and shopping, let's say, and tendering that is very informed and that learns from best practice, both in, you know, developed country health systems as well as in the private sector. And we're not there yet. I mean, we'd like to, you know, if Amazon takes over, someone suggested that in the previous panel, or wombo.org becomes the global health Amazon. You know, it's like you can imagine a Consumer Reports kind of thing. They do this actually in the device industry. They show you a set of comparator technologies. They show you the relative cost effectiveness. They show you all the bells and whistles. They show you price, and you buy it, just the same way you would look for a refrigerator. We can do those things. We can make the ECRI consumer reports available to more purchasers, for example. We can make something like that available in medicine. So that's one thing to think about. And I completely agree. Regulatory harmonization is hard is the only problem. So in the meantime, I guess we should always aim for the first best, but we should also try and think of plans B, C, and D. On the question of where the puck should be going, I agree. It is sometimes striking that the IFC has funded mainly tertiary hospitals and dialysis clinics, but I think it reflects what the demand is in low and middle income countries. And I guess the question is, how are they making those decisions about the use of public subsidy? How are they allocating resources? And do they have even a formal resource allocation mechanism that allows them to think about the whole health system and the set of services they would like to provide and what the criteria are for deciding what would be a priority service and what would not be? And in the best, there's like a virtuous path and a vicious path. And I think Latin America actually is very interesting to look at, because there's countries that from day one were quite intentional about selecting the more cost-effective interventions that would have an impact in health, and other countries that were more inertial. They let demand decide where they would make the next investment, and you can see the difference in outcomes and equity 10, 20 years later. All of them have ended up actually in the same place, which I think is close to getting there at least. But I hope that we look at regions like Latin America for signals of how more deliberate resource allocation can lead to better outcomes. Thanks.
Excellent. Thank you both very much. I might take the facilitator's prerogative to just ask one more question directly and then ask again from the floor. But Amanda, since you mentioned Latin America, and a lot of people point to family planning graduations in Latin America as a potential analogy to think about this broader transition, would be interested in your thoughts on that. And Johanna, I was also just realizing as you were speaking about the potential role that technology firms could become our next big health service delivery firms, and especially in the U.S., there are a lot of discussions about privacy concerns and safeguarding that private information, especially with your role on policy and advocacy. How do you think about balancing those competing interests and those concerns while also tapping into those resources? So let me just plant those two and then see if there are any other questions from the floor.
Okay, I think I'll go. I'm here.
Yes. There are multiple hands. Please go ahead.
Oh, okay. I've heard a lot about preparing African governments for allocation, for doing procurement, and quite a number of other things. At the same time, a lot of the presenters talked about political will as being the determinant of what happens and the government's needs and where the government's priorities are. So I'll give an example. If I say today that my priority is investing in public health, and I come from Kenya, which I have said, which is something that has happened, and investing in a strengthened community health system, the answer that we have received from partners as we think about our transition is, my funds are for commodities, my funds are for this, my funds are for that. So I think we have a disconnect in this conversation around transition, because on the one hand there is, we want to invest in the needs and this is what we need, and on the other there is, well, I can't fund that because that is not what my allocations are for. So as we have this conversation, I think it's really important to start to ask ourselves, I think it was the gentleman who said, what is the narrative for the transition? And is it actually a transition, or is it a conversation we are having about why it's good to have a transition and think about it, and then start to plan around what that looks like, so that the conversations and the priorities actually begin to match. And so the question, I think, would be, how do you deal with these differences and these realities, because that's part of the biggest challenge. It is never going to be the hardware for the transition. It is going to be the software that will drive whether transitions become successful or not, and what do we need to do to deal with those now.
Excellent. Thank you very much. Go ahead.
John Monahan, Georgetown University, and this is a question for Amanda. It seems to me, I agree with, I certainly agree that regulatory harmonization and cooperation would be terrific. I agree with Sir George. I also think that that's very hard. And I agree with your point, Amanda, that at least in the near term, it seems strengthening country capacity there becomes really important. So at least in the Global Fund experience, it seems to me there's two broad categories of skills. One is this set of business skills around information and analytics, everything you've talked about that helps you get value and low prices. But then there's the point you made about the enabling environment around policy and regulatory capacities in country. And so I guess, do you have any examples of where countries have successfully put that regulatory and policy and legal environment together, and who would be the right international, if the hypothesis is that having more countries build those capacities faster, who would be the international partners that ought to be at the table to help facilitate that capacity building? Because it's not the usual suspects, I would argue, in global health.
Great, thank you. I think just two more questions. I think I saw Equo, and then one over here. Go ahead.
One comment and one question. One comment is that coming from Japan, I really strongly believe that the prevention is better than cure, and we need to really incentivize investment to make the health society more like a health promoting than simply promoting the investment on the cure side. So that's, I think, very important. And second, my question is to Amanda about the role of private health insurance. That's something we are kind of struggling to have a strong position on, whether to promote or not. Because if you look at the countries, which I'm not naming the countries, but who rely on the private insurance, is the countries where there is a big discrepancy or inequality in health. So there is, of course, a need, the demand for some kind of health protection when there is the public sector is still growing. So I'm sure that in low and middle income countries, the HMO kind of services are growing, but we are not really sure whether we can really support it proactively, considering what will be in the future. So thank you.
Thank you. And one more from Jenny.
Yeah. Thanks. First, wanted to agree with everyone and echo Sir George's comments on not focusing on the dead, but keeping people alive longer who are currently living with NCDs. And sort of from the high-level commission perspective, that was sort of what our deputy secretary took, the charge that was given to the commission to work on member states achieving their SDG goals, which is to reduce premature mortality by 1/3 and by 2030 as sort of what's the evidence and what's the most efficient and effective way that member states, that we can advise member states on doing that. And so I think it is a narrative that we need to be talking about, is to say, how do we keep people alive longer that currently are living with NCDs? On the regulatory harmonization part, in the multilateral space, we're also trying to work on ways to sort of bring this conversation into different forums, whether it's G20 or just at WHA. And as we always sort of try to talk about, are there any low-hanging fruit options out there in regulatory harmonization? There's some countries that have, I think in the Americas region, that have started sort of in the approval process part, referencing back to stringent approval process. And I don't know if my FDA colleague is still here. They probably know more about this than I do. But is that an option of just trying to get more and more countries to work on their approval process, and that there are other barriers to access to healthcare products that we can work on within getting them, more reliable approval? And so that would be sort of my general question to y'all, is what are some of the low-hanging fruit?
Excellent. So let's start with Amanda, especially since several of those were directed at you, and then Johanna will give you the last word.
So on family planning graduation, I think, actually the USAID's family planning group has completed many successful transitions and even had its own set of criteria for transition. And one question that I have is, as the agency thinks about its overall transition strategy, how does that fit with the specific, family planning versus PEPFAR epidemic control versus something else, each of them would have their own criteria, so it would be interesting to see how these things intersect or not. But what, the best cases, obviously, were what's really interesting is that much of the family planning provision that was financed by the U.S. government went through non-governmental organizations for various reasons. And they were pulling out at the time, and they had not transferred to government supply. And what they did in some cases was to provide an endowment for some of these non-governmental organizations to operate, and then some technical assistance to say, look, go to government, see if you can get family planning listed on the list of benefits that would be reimbursed or paid for by the public sector, social contracting, basically. And those are the best case scenarios. In some cases, governments took on the direct provision themselves. In other cases, those NGOs continued to provide care. Some of them never got any government money. And I would say, no transition will ever be 100% successful, but I think it is sort of encouraging to look at that experience and think about what we could learn from that for other sectors of global health. On the issue of what is a good example of that double set of procurement strengthening functions? Maybe we should call it something else so it sounds more appealing. I think people do say that South Africa, for example, has had a very, looks good in terms of the kinds of volumes and arrangements that it's making. It has led some partnerships with neighboring countries that are quite interesting. So I think maybe we should dive in a little bit to those country cases to understand why they're doing so well. And in fact, Kenya, KEMSA was such a good example for many years of getting smarter, the Cameroon example that I gave you. So I think we need to look at those cases closely and learn from them and see how we could structure a more integral offer. Who would be the international partner? Good question. I mean, you of course think of the World Bank for some of these, or the regional development banks for this kind of support. My only worry is that they have been doing public procurement strengthening for a long time, and they don't look at medicine and devices in the health sector as a special case until quite recently. And I think we know that it's quite different to look at on-patent products, for example, and buy on-patent products. So maybe what we should say is that these multilateral development banks are a good partner, but maybe they need a special initiative that focuses on health sector procurement and procurement strengthening. You mentioned the problem of donor earmarks. So the answer is yes. I mean, maybe some would say there's a pendulum swing back towards supporting country-led programs and budget support and things like that. Maybe. I haven't seen it in Kenya yet. I think it's very tough. I think really a government that wants to grow its own UHC scheme probably needs to pretend that the donor money doesn't exist right now. That's where I would start. And then I would say, okay, now you come in and yeah, you can co-finance my benefits plan and okay, you're only willing to do this, fine. But I would assume from the start that it's my budget envelope, that I have certain goals, and I start to act from there, and things will fall into line, maybe. Hope for the best. And then on private health insurance. So I'm actually working on a paper on that as we speak, so maybe I won't answer your question yet, but instead be in touch with you after I finish. But one thing I'd say is, if you look at countries that have a big private health insurance let me back up for a second. First, if the public sector can only fund a certain amount for the next 20 years, actually you do want to have more private health insurance or private pooling to be able to cover some of that out-of-pocket expense as much as possible. That said, there is a kind of perverse political economy that can occur. We now have, both Brazil and South Africa have all of their public employees enrolled in private health insurance. And then they say, oh, well, the rest of you go to the National Health Service. That kind of system feels very uncomfortable over time. And a country like Colombia, for example, decided, gosh, I'm going to have a Netherlands style or a Switzerland style. I'm going to have all kinds of health insurers, and I'm going to pay them a package, and they're all going to compete with each other. Countries will go in different directions on this. And of course, they're very polemical and ideological views on what is better or worse. I think you can get to the UHC whichever way, Obviously, it should be done right. Obviously, we should be regulating private health insurance in a way that contributes towards universal health coverage goals rather than diminishes it. But I think once you're living with private health insurance, which we are in a lot of countries, then you should recognize that it exists and not pretend like, oh, I'm just over here. So that would be good. And then regulatory harmonization, low-hanging fruit. I feel like there's none. But I guess one thing to say is a lot of that regulatory harmonization work has focused on capacity building. And my thought is maybe we should, and I know that everyone who's doing it has this in mind anyhow, but maybe we should really focus on the political economy issues around the role of the national regulatory authorities and what we'd like to get done. I mean, if we really want to increase access to markets of generic, quality assured medicines, those manufacturers, we want those products in, like, okay, let's figure out all the, that there's 10 things that we could do now that would make that easier. And we may have to pay for things like, I'm going to pay your fee in lieu of having the manufacturer pay. But the other issue is that there's the local manufacturers that are there. There are buy local requirements. We need to have some view about the NRA's role with respect to those local manufacturers. If they're not going to assure the same level of quality and there's no political will to do that, we're in a pretty difficult pickle that is not so easy to deal with. Thanks.
Great. Johanna?
Amy, to your very challenging question around data, I think the answer is it's complicated. But one thing that we've been through in Europe recently that I think will actually teach us some things is around GDPR, the Global Data Protection Regulations that just went into effect on May 25th. And being a veteran of running an organization that we all had to spend like all hands on deck for the month before, just trying to get all the permissions. It's no easy feat, but there may be some learnings from that simply because it's a block of countries that is trying to get their arms around it. I think the key point of it is that they're trying to drive the decision-making power much more towards the individual and the consumer, and that sounds good in theory. We'll see how that plays out, but I think we'll be able to learn from that. I do worry. I think one of the other sort of big issues in this space is around private sector data, and there's a range of feelings from supportive to not supportive around how public and private sector data might be shared as well. So private sector sharing amongst itself and within itself, and avoiding issues of collusion and all that, but also more broadly the validity of that data. How's that data being collected, or how are that data being collected? And it's a missed opportunity if we can't get our heads around how that happens. So I think let's look to the EU, either for what to do or what not to do. I also have the added joy of having an office that's based in the UK, so it's like this is the EU, and then there's Brexit, and Brexit, as it turns out, isn't going that well. So it's the transition isn't going that well in this other transition that I happen to be in the middle of. So it's a tricky area, but my recommendation, just because I think what GDPR is trying to do is very interesting and potentially quite instructive for a wider framework and model. For earmarked funds, yes, absolutely, that's critical, and I think also because earmarked funds don't sometimes disguise what is actually being funded, and I think one of the areas in the NCD community that we did was work towards getting an OECD purpose code, which turns out to be really, really, really hard and take a long time, but finally is going into effect, which is to essentially track funding for NCDs in a way that's a little bit more intentional and accurate than has been the case. We use those 1% to 3% figures in terms of what's going into development assistance for health funding towards NCDs, but don't actually know whether some health systems funding, cervical cancer actually sits outside of NCDs often and sits in reproductive health. So there's it'll always be tricky to track, but there are some steps that can be taken. In terms of treatment, I think in the spirit of the multi-sectoral approach, but also because I think it's critical, we need to think of treatment as more than medication, and it needs to be food is part of treatment, very much, and other elements are part of treatment, and so a broader view of what treatment constitutes, I think, is the only way that we'll be able to sort of do our jobs in terms of addressing these health challenges, although I know it introduces its own set of complexities. But I think many diseases are a logical response to the environment around them, and so if we don't think of treating the environment that is around the disease, we will not be successful in addressing those diseases. And that, pollution is another one for chronic respiratory disease, for cardiovascular disease. And that's the regulatory, that harmonization piece, harmonization across not just healthcare procurement, but food and tobacco and other air, all the things that we live in. And so, we can either get overwhelmed by it, or we can say, well, wow, this is a great opportunity to take a very, very holistic approach, and that's what the transition is. And I would like to think it's that, and I think there's lots that can be done together around that. The only other comment I wanted to make was when we say Latin America, we need to include Latin America and the Caribbean, and the reason I say that is because from the NCD perspective, the voice calling saying this is a problem that made such a magnificent difference was from the Caribbean. And if you don't know what a hero Sir George was in that movement, he's so modest, and he'll probably be annoyed at me for saying this, but it was those, we need to also be listening to different voices from different places, and I think the Caribbean has been a really, really interesting voice in addressing many of these issues, and I want to just acknowledge that, because sometimes it gets lost, particularly just even categorized with Latin America, but the Caribbean's been an amazing partner on some of these issues. Thanks.
Well, thank you so much to you both for an excellent discussion into this engagement. We will not forget the Caribbean. We will not forget the living. And there's no low-hanging fruit, so we have our work cut out ahead of us. Thank you so much.